Welcome, everybody, to our last week of the Caribbean Climate and Health Responder course. It's amazing, and congratulations to all that you made to here. And I'm just going to wait a little bit, just one more minute, so participants can join us. And just to remember you, that we have interpretation, you just need to click on the button on the bottom of your screen, and you can have translation in Spanish and English. I will wait a little bit more. Okay. So we are in the session number 9, and today we are going to discuss the healthcare sector mitigation and adaptation. The learning objectives of this session is to apply the concepts of mitigation and adaptation to the healthcare sector and explore examples of how healthcare system can perform both. We are going to identify ways in which healthcare facilities can become more resilient, for example, by employing the PAHO Smart Hospital program. We are going to learn how to use emergency planning skills to plan for and respond to climate-related extreme weather events and disaster. And we are going to understand how health professionals can partner with healthcare institutions, professional organizations, and advocacy groups to reduce the healthcare sector greenhouse gas footprint. As you already know, this session will have 90 minutes, and at the end, we will have a Q&A. If you have any question, please put your question to the speakers in the Q&A. The video recording and reference materials and slide decks will be available in the website, and we will also be sharing in the WhatsApp group. If you need CME credits, you can apply for each session that you attended for. The application will be posted at the end of the course. You have to complete a Google link, and the link will be live until 12 p.m. of the following day. And this is a very new information, so pay attention. We will have a final exam at the end of the course, and people that had attended 7% or more of the live Zoom sessions and passed the final exam with a score higher than 70% will be awarded with a certificate of participation in the climate and health course from the Earth Medic and Earth Nurse and the Global Consortium on Climate and Health Education. And participants must join each class session using their personal unique Zoom links and complete the final exam using the email address used to initially register for the course. I'm going to open a parenthesis here. For Cuban participants, we are considering their attendance asynchronously and also in the live YouTube session. But for the other participants, you need to attend 70% to be eligible, 70% of the sessions live in Zoom to be eligible to the certificate. So the exam will be sent out on the final day of class via email and also WhatsApp. The exam links start on May 2nd at 8 p.m. and will close on May 4th at 8 p.m. So you have 48 hours to start the exam, the test. The format of the final exam will consist of a combination of multiple choice and true or false questions. And as participants should be prepared to take the exam in one sit. So if you started, you have to finish. Even if you have more time to complete the 48 hours, but if you started, you have to finish. There is no limit of time. You can take your time, but you have to complete it in one sitting. It will not be saved, so pay attention. And certificate will be awarded in the middle of May and will be sent by the email of GCCHE. So take a look on your spam and your email box. So today we have 3 presenters. We have Ms. Antonella Risso, Ms. Julieta Frederick, and Dr. Judith Harvey. So I'm going to start with Ms. Risso, who is the founder of Ambiente Sano and an environmental consultant with over 15 years of experience working on the diverse intersections between environment and health. She has developed projects and tools focused on sustainable solutions for the region of Latin America and other regions. Over to you, Ms. Risso.
Hello, everyone. And the dogs were mine a few minutes ago. I'm sorry. So can you see my screen now? You can, right? But let me...
Yes,
okay.
perfect.
Yeah, it's working. Perfect. Okay. Thank you, everyone. I'm really glad to see there's over 300 of us today and from many, many different countries, including Argentina. I'm very happy to see that. But I'm going to speak in English, but in any case, I speak Spanish too. So we're covering today, as presented before, learning objectives today. We're going to talk about mitigation and adaptation in the healthcare sector and explore some examples and these links that Daniele was mentioning before to identify some ways in which healthcare facilities and systems can become more resilient when tackling climate change. And a few more, my colleagues are going to talk to you about emergency planning skills. And also we're going to talk about how healthcare professionals can partner with health institutions and some initiatives that are super interesting in Latin America and in the Caribbean that you have available. So from last session, because last week, John Karen Paulson from PAHO talked to you. So this is just a reminder of that the healthcare sector is contributing to climate change. Depending on the country, this could be 4% of total emissions or 10% of the greenhouse gases that the country emits, like it is the case, for example, of the United States. High polluters, like very big countries that are high polluters, the healthcare sector emits more. Countries that are not that important internationally in global emissions, the same happens, and depends on the size of the healthcare sector too. And the estimation is that if the healthcare sector were a country in the whole world, it would be the 5th largest emitter. So if we take it all together, it is relevant. And the important thing here that as all sectors, we need to change. If we're going to tackle climate change, we need to change how to do things. And in the healthcare sector, and this happens to other sectors too, more of the, like most of the emissions, in this case, around 60-70%, depending on the country and the sector, 70% come from the supply chain. They are not from the building and direct operations. They come from the supply chain. So that is where it gets tricky. And we're going to talk a bit about that today. And so it is crucial for the hospitals and healthcare systems in the Americas to boost their mitigation and preparedness. This is what Dr. Paulson told you today that I fully agree with. So one of the things that I wanted to show you, this is outside the healthcare sector, how total, I'm missing an L there, greenhouse gas emissions evolved in the past few years. So total anthropogenic emissions, we're saying, caused by human activities, greenhouse gas emissions from 1990 to 2022, you see that that's still growing. And we should have changed that by now. This should be going down, and it should go straight to zero in the 2050s and beyond. So we're not there yet. So that's one of the reasons we're talking today, and more sectors were pushing for this to change. And if you look here, you're going to see a few things, like that tiny or slim orange line there that is getting bigger. That one, it's F gases, for example, cooling gases. And follow me with the thinking here. One of those gases, part of those gases, are the cooling gases. So healthcare sector uses a lot of cooling for vaccination, for example, freezers, for air conditioners, and we know that we're going to need more in the future. So, and this happens with the same healthcare sector too. We need to grow. We need better healthcare, more healthcare, almost everywhere in the world. So we need to grow. And we're going to need more cooling. But how we do that, it's what we're trying to develop together, the answer to that. How do we create climate resilient and low carbon and sustainable healthcare systems? How do we get to universal and effective health coverage and at the same time reduce emissions, reduce pollution? That's not easy to do. We're trying to get the answers globally these days with more and more countries estimating their own contribution to this problem and developing their strategies to solve this. If you have questions, I can answer those, but the thing is easy. It's like most of the emissions come from CO2. This is fossil CO2. The second one is methane, that some of that come from cows, rice, and also, like, for example, if you heard of fracking gas, fracked gas, that too, those are the sources of CO2. And we also have these F gases that are getting bigger due to these more and more cooling needs and access to cooling, because people that didn't have an air conditioner, maybe now they can afford it, so they have it. That's more cooling. And the green one that says LULUCF here, this is wildfires, deforestation, land use change. All that, you see, it is relevant too. When deforestation brings more emissions, and the same happens with wildfires. So this is total emissions in the world and how they keep growing. And the current situation, if you want to read more, there are some things that I'm bringing to you here. In the past slide, you have the sources below. And you probably heard of UNFCCC and IPCC. What is the global stocktake? Maybe you read about it, maybe no. But in the Paris Agreement, this is the first stocktake balance that we made. It was published last year as part of the negotiations, in the climate negotiations. So what the global stocktake said, greenhouse gas emissions need to be cut around 43% by 2030 and 60% by 2035 from 2019 levels. So that's a lot. If it's doable or not, that's under discussion, and who needs to do most of this. But it's a huge. And you see here in this graphic that is connected to the historical emissions, where we are and where we need to go. That is slide down to get to 2050. And here you can see scenarios. They are always building scenarios. In the light blue one, likely below 2 degrees, because global average temperature that is going up, that we should stop before it goes up to 1.5 Celsius degrees or 2 Celsius degrees. Those are the commitments under the Paris Agreement. If you don't know what I'm talking about, please ask and I can answer. We need to do that, and we're not in the right path. That's the very simple answer here, that we have an international commitment. All countries that under the UN signed it, it was signed only in 2015. It wasn't signed 50 years ago. Just in 2015, countries committed to stop global warming before it takes 2 degrees or 1.5, but we're not going there. That's the truth. We're far from it. We're in the wrong direction still. We're making some progress. We're still far from the goal. And that talks about all sectors in the economy, really. So we need to reduce all this if we're going to stop global warming. So, and countries also recognized in the Global Stockdate that adaptation was no longer a choice, but a matter of urgency in the face of intensifying impacts of climate change. This is the other side of the coin. Not only we are going to probably exceed the 1.5 in the following decades, but adaptation has become, and many of you know this and are living it, impacts of climate change are quite a reality these days. They were not 10, 15 years ago when I started going to the university. Some of these were things of the future. And that's no longer true. For example, with dengue fever, tripling and really creating a huge challenge for our countries and our healthcare systems. So at the same time, we are in the healthcare sector tackling climate change, taking the impacts, dealing with the impacts daily in all of our countries. And at the same time, we're a sector that needs to grow, and it's quite highly polluted in some cases. So we need to change that. So we're going to talk about that. We're not in the right direction. You have all the links there in the slides. And this is also used. This is a report, the emissions gap report. It's a very important report that we usually read. It's from the UN Environment Program. It's from UNEP that also talks about this, that in case you're interested, you can see this, like the current policy scenario, because it's not the same what they have committed to do, that the policies that are in place today. With the policies in place today, we are not getting where we need to go. This is some NDCs are the commitments that our countries do with the Paris Agreement, like UNFCCC. They make a commitment. They need to update those. The NDCs should be updated this year and next year. Our countries, formal commitment to the UN on climate change. With the commitments that our countries made, this is unconditional, and condition depends on funding. But with the commitments that our countries made, we are very far from the goal. And what we need to do, it's the light blue and the green again. So we're very far from it. So that's where WHO, PAHO, many countries are making commitments. And actually was interesting a few years ago when the NHS from the UK was the first national healthcare system in the world to set a plan, a real plan, funding and structure to get here, to make their own path here, to make their own net zero plan to 2040 in this case. And that was the first one. And after that, others came, and many countries are right now trying to develop their own strategies to just do their bit. And one thing that I wanted to tell you is that last week, on April 25th, 26th, I think, the Lancet Countdown Latin America Effort on Climate and Health, they launched the new report. Last year, it was Lancet Countdown South America, but now it is Lancet Countdown Latin America because it has data for more countries, and that is super interesting. It's an effort that is providing us with data from our countries that we didn't have before, with metrics and an effort and researchers from different countries in our region. That it's super interesting. So now the Lancet Countdown has data from 17 countries. It added Mexico and 5 Central American countries this time: Costa Rica, El Salvador, Guatemala, Honduras, and Panama. Argentina, Chile, Colombia were already in this effort. And it has 3 key messages this time for Latin American countries: that we require intersectoral public policies that simultaneously increase climate resilience, reduce social inequalities, inequities, improve population health, and reduce greenhouse gas emissions. This is our challenge. How do we do this? And that is why we need networks and efforts like this, because no country can do it alone. And there's no system that can do it alone. And we are creating these communities so we can all solve this challenge, huge challenge that we have. That we need to accelerate an energy transition that prioritizes people's health and well-being, reduces energy poverty and air pollution, and maximizes health and economic gains. And this is the first graphic that I showed. Most of the emissions, that huge chunk of emissions that come from fossil fuels, that is the energy transition that we need to make. And that's not only cars, it's how we produce electricity, how we produce steel. Everything needs to change so we can actually change that. And we need to increase climate finance through permanent fiscal commitment and multilateral agreement, development banks to pave climate resilient development pathways. Because as we said, like adaptation is no longer a choice, it is a need for many countries, for most of the countries actually, and there's no enough funding for adaptation nor for mitigation. And actually some of our countries that now that you're here are leading conversations on some of these things, how to compensate countries that are getting most of the impacts of climate change and very little of the responsibility of it happening. So these are all the international discussions, but they are all linked to what's going on in the healthcare sector and why the healthcare sector needs to adapt to climate change, but mitigation is part of that conversation too. Health-centered climate action is essential today, and it could render immediate health effects, the benefits. And the full paper, it's available, it's open. This is the Lancet, but it is completely open, so you can read it. It was launched last week. So let's talk a bit about climate change mitigation and adaptation in the healthcare sector. Just in case, a friendly reminder here on mitigation and adaptation. Mitigation, this is the official definition of this, refers to human intervention to reduce greenhouse gas emissions or enhance the sinks of greenhouse gases. For example, forests, native forests, or the ocean. And adaptation, it's a process of adjustment to actual or expected climate and its effects. Actual or expected impacts. In human systems, adaptation seeks to moderate, harm, or exploit beneficial opportunities, but there are multiple benefits too. In natural system, it's expected, adjustment to expected climate and its effects. So a natural system can adapt to climate change too, but usually we're going to be talking about healthcare system. It's a human system. So mitigation and adaptation. We reduce emissions or we adjust to impacts and effects. So why mitigation in the healthcare sector? Part of this was told by Dr. Paulson last week, but the sector represents more than 4% of global emissions. So it is quite interesting as a sector because it's the same inside the country. You have one sector that is an essential sector, healthcare sector, that represents an interesting percentage of the emissions. All sectors need to change, as I told you before. I strongly believe this, that if we're going to tackle climate change, we all need to change, and that is not easy. And the healthcare sector needs to grow and adapt to climate change, minimizing its own contribution to the problem, as already said. So why mitigation in the healthcare sector? This comes from the Lancet Countdown data platform. This is if you don't know the platform, it's a very good place to play with data and indicators related to climate and health. If we see all countries, here we see how emissions are distributed. So you see African countries, like the countries with less health life expectancy at birth, are the least responsible. The highest ones are more responsible. So it's Europe, Western Pacific, and this is United States and China probably, and the rest are very, very different. And when we see the Americas, if in that same graphic that I showed, in this same graphic, you can turn on and off regions. So if we see only the Americas, I added this manually because this is one thing that the graphic doesn't show, are the countries. So the USA, of course, it's in the Americas, it's the largest emitter. But if you see Canada has higher life expectancy at birth with a lot less emissions. And like the same, of course, there are other parameters, of course, but if you see just this, life expectancy and emissions, maybe they're not related that much, but they're a bit. And we have here Bahamas, we have Venezuela, we have Peru was this one, Haiti was this one. So if you can play with a lot of the data from the Lancet Countdown metrics, but if this is only global, we don't have this like separated, like just a Lancet Countdown Latin America data platform. This is the global one, but there you can separate numbers and you can see all the metrics that they have. They are not only on mitigation, they are also on the viability of Aedes aegypti in different places in the world, an exposure to heat, wildfires, and also on funding, and if countries are developing some plans or not. You have all that in the platform. And one of the reasons, I don't know if you saw this before, but these are called warming stripes. So this is how warming is moving, right? And this on the right, I don't know if you, can you see my cursor for the ones?
Yes, yes.
Can you see it? Okay. These are scenarios, right? We have today and 2100. And these are like possible futures. We have very high warming, high warming, middle warming, low warming by the end of the century. And the thing is here, like not much warming. It's very unlikely these days. We are more in the low middle area these days, like in these scenarios of more warming. And this is how this is a reconstruction. And you can see this per region. And actually, I think, I don't know if per country, but per region for sure. And actually, I have now, I have a bottle here. This is my water bottle, has the ones. This is the South America one. These are the warming stripes from South America until last year. We are warming as everyone. And every single fraction of a degree matters. And as you are healthcare professionals, you probably understand how fever works and that a degree and a fraction of a degree matter if they stay matter. And this is already affecting oceans, our forests, and us. This is an adaptation that with my team we made of a graphic from the UN, from IPCC, from the last report from last year. We adapted this one, so we believe it's a bit more easy to understand right now. This is one good thing that they did that I think is very good because it's hard to understand end of the century sometimes. So in 2060, I'm going to be old, but I'm going to be alive, probably. So if you were born in the 80s, I'm from the 83, in 2050, you have 70 years old. So when we're talking about 2050, I'm supposed to be alive. So those warming scenarios, I'm going to be there. And it's going to be when kids that are born right now in the 20s, it's their own adult's life. So why is this important? Because to be able to stop climate change, we need to stop emitting now. And why? Just because the gases stay there. And if you have worked with toxics before, there are many that we just stopped using because they stay there. And we cannot extract them from the atmosphere easily. There are many trying. They are trying to do that, like fossil fuel companies. They are trying hard to do this effectively, but so far it's not working. So what we know that what works is to stop using the toxics that the healthcare sector knows very well. When we have a toxic, we replace it with something that is not toxic, or we just stop using it, because if we can, we protect ourselves from it. And if we cannot protect from it, we stop using it. We know it very well in the healthcare sector. The same happens when we talk about the sources of greenhouse gases that cause climate change. So this is a good one if you want, just use it. But you're going to please see that it is an adaptation from the IPCC. You're going to see that it's not exactly the same graphic. And it shows this, that what happens when, depending on when you were born, these scenarios, how affect your own life for the people around us. And why adaptation in the healthcare sector? Healthcare sector needs to respond to increasing pressure, and it is impacting Latin America everywhere. According to the 2023 Latin America report from the Lancet Countdown that I showed you, was published last week, there's a warming trend in all countries, of the 17 countries that the study has. Millions of people are currently exposed to a dangerous levels of air pollution and energy poverty. The report talks about that too. That is access to energy, clean, safe energy. And there are some estimations on premature mortality attributable to fossil fuels. And do you know what PM 2.5 are? It's air pollution, like very, very small particles that go to your bloodstream and are quite dangerous. And increased exposure to heat waves, wildfires, and vector-borne diseases. That with dengue this year we know really well, and with wildfires and heat waves, I think most of us are just experiencing those, and it's quite obvious, but the data just reflects that heat waves, wildfires, and vector-borne diseases there's just more exposure to them in all of our countries. The region had a 140 increase in heat-related mortality from 2000 to 2009. If we compare 2 decades, 2009, and 2013 to 2022, 4 years, there's a lot more exposure to heat waves. You can see this in the data if it's hard to understand right now, or I'm confusing you. But the thing is that there's a lot more heat-related mortality and a lot more exposure to heat in our countries just in these past few years, just in the last 20 years, not in the last 100 years. Just in 20 years, we're seeing this, and I think probably dengue is quite the most clear example of how it's not what's happening with climate change impact, is that it's not a 2 or 3% increase between years. We are jumping, we're taking leapfrogs with many things. And that is challenging our systems. And changes in ecosystems, this is something that the report also covers, have led to increased risk of wildfires too. That happens in many of our countries with land use change. So just here as a reminder, the healthcare sector contributes to global greenhouse gas emissions, and it's also dealing with the impact. So how can healthcare facilities become more resilient and reduce emissions? I don't know if you saw this one, but probably you did. The new operational framework from WHO that was published last year. And with the building blocks, but the only thing that I'm covering today is that with this building blocks of healthcare systems, we have this core systems that have many components. And we have just 4 here on the right, just using my hand. We have that are components of that today that were not there 10 years ago, but they are there now. Not only 5 years ago, but now we see this and we have agreed on this. We have the assessments of climate and health risks and greenhouse gas emissions, both your risks and your contribution to the problem. Both are here in the light green one. We have integrated risks monitoring, early warning, and greenhouse gas emissions tracking. Here, health and climate research that we need a lot more of. And we have here climate resilient and low carbon infrastructures, technologies, and supply chain. So all these are building blocks of a healthcare system today, as we have agreed internationally. So all this is part of what we're seeing today. So if you start working on this, you are going probably to cover all this from the new frame. And you're going to need a lot of the others. You're going to need the climate smart health workforce. You're going to need transformative leadership and governance, for sure. You're going to need sustainable climate and health financing. You're going to need preparedness and management, as my colleagues are going to talk to you about later on, climate-informed health programs, and management of environmental determinants of health. All this to develop climate-resilient and sustainable healthcare systems around the world. And one thing that this comes from my team too, and this is under development, I'm seeing the time. We have priorities when we talk about mitigation. There's something that we call a mitigation hierarchy. We talk about avoiding emissions. We have a car here showing it, a bus. Avoiding emissions. This means, for example, in some countries, this is doable. You have a policy for people not to use their own cars to go to work, and they have a bus, train, bikes. You're avoiding emissions. You are reducing emissions. When you're avoiding, if you're using your bike, some electricity seems to be challenging right now. You can avoid emissions, changing a source of fuels. For example, you change something that is fossil fueled to something that is electric. You are reducing your emissions. You are avoiding when you are using, for example, I'm going to show you a bit when you are changing, not using the fuels at all, and you're compensating. This is something in the healthcare sector is rare, but when you're compensating residual emissions, we say, the ones that you cannot change, you compensate. But in the healthcare sector, this is less important because we need to focus on those, avoiding and reducing, and not the compensation. So to explain that, in the avoiding emissions, and I don't know if you are expecting like technical data on mitigation, but I can explain you how another time how emissions are calculated, how systems really calculate their emissions. But this is a picture that I like from this is in Cali in Colombia. This was a primary healthcare facility designed not to use air conditioning at all. Cali is a very hot place, hot and humid. Designed not to require air conditioning at all in all the common areas. They use it like where the doctors were, but in the common areas like this one, it was designed not to use it. And I was there, so I witnessed how it was super cool without using. This is called like passive cooling. It's designed. So that change, that requires a cultural change, like a different mind. When you're designing, this is avoiding the emissions. When you're designing a new infrastructure, can I just not require the energy at all? Not require the air conditioning. And many times you can, sometimes you cannot. But if you can, this is the avoiding. The energy efficiency too. If you are just buying or using something that requires less energy, that's avoiding emissions. And that is the first priority if you want to work on mitigation in the healthcare sector. The other thing is reducing. This picture is also from Colombia now that I'm thinking, but from Pasto, from the south, a colder area. Colder area, rainy area, cloudy area, where renewables also work, because they work quite everywhere, actually. So in this case, you are replacing fossil fuels. In this case, were boilers to heat water. Now they are heating water with this, with solar heaters. This is what they're using. Yeah, I think solar heaters is the word. Just correct me if I'm wrong with the English here. So this is one of the cases when you are reducing emissions. This is your second priority. First, you avoid the emissions. You cannot avoid them. Okay, let's see how we can reduce them. This is how we work on mitigation, and in many times adaptation at the same time. Because if you were using, let's say, LPG, because you don't have like a grid, like we have here in Argentina, because we are gas producers, and so we have it, but in many other countries, you don't have it. So being able to produce your own electricity or to heat the water that you need gives you independence. So it makes you more resilient. So this is where you have like multiple wins many times, like when using solar panels or solar heaters, or requiring less energy because your building was designed, like many probably of you know, because it's a PAHO program, the smart hospitals, it's about that. That's being smart. And it's probably going to be cheaper at the same time. So this is all that, like what mitigation is actually on the ground. And another one, this is a good drone picture of a hospital in Argentina. When they estimated the carbon footprint that I told you that most of it comes from the supply chain, one of the things that we saw in Latin America, in many hospitals, when they were estimating their carbon footprint, is that in the cities are places where people go to work by car. That represents a huge proportion of the emissions. And this is the parking area of this hospital that is actually bigger than this because the trees are not allowing us to see everything. But I don't remember the number, but it was, hundreds of cars that go to the place every day just from workers. If you add that from patients, you see that when you are talking about mitigation in the healthcare sector and in healthcare facilities, you need to talk and see a lot more than just the electricity and the energy that you're consuming. Because your operations have a lot more. For example, how many cars go to your places everywhere, every time? How many? And it's super interesting, right? Last year in hospitals that have more than 1,000 workers, if only 30% of them go to work by car, that's 300 cars if they don't share every day. So is there another way to do it? Sometimes there is. And it's something that to explore. And that not only to explore, it's actually we have to in the future. And if you continue this conversation, you're going to see, as I said before, and the Lancet Countdown main message was, we need intersectoral policies. And this is one of the reasons. If the healthcare sector wants to go to zero emissions, you cannot solve this by yourselves. There's no way. You need city policies, state policies, national policies to be able to do it. And this compensation, as we said, only after full implementation of the previous, you go here, that in many places, it's not going to be probably useful for you, but probably in the private sector and big private companies working in the healthcare sector, they are usually compensating and buying carbon credits and to be able to claim that they are something that is called carbon neutrality. But that is something that I don't think it is relevant for you at all. And that is not what the healthcare sector should be doing. So I'm saying it only after all the rest is done, go ahead and compensate. And this is another thing that we wanted to, it's quite complicated. But when we're talking about adaptation and resilience, and I need to take some water, sorry. And how am I with time? Do I have 5 more minutes? It's 45. I don't know where we started. That we have capacities and opportunities, and we have multidimensional vulnerability, and we need to build resilient and reduce risks. And for this, we need to respond to climate change. We need development pathways. And all this, it's where it is really entangled here, and that's how it is. Because all this affect resilience, and I'm seeing, Haley, that you're writing, so I'm checking how am I with time. 5 more minutes, good, okay. But I'm going to jump this because it gets too complicated. So this is just for you to have and to see later, to see in the slides, because I'm giving you many, many links. When we have here climate change today, we have the risks today, we have the greenhouse gas emissions here that are fueling climate change. We have adapt and mitigate at the same time. We're trying to solve this because we have, for example, with dengue fever, let's use that example. Climate change is fueling it. It's making the mosquito is adapting even in Patagonia, where I live, the north of Patagonia in Argentina, where we usually claim that we don't have mosquitoes when people say how it's summer there, and we say we don't have mosquitoes, and we believe that's a very good thing. But now in the north, not only there are mosquitoes, but dengue is coming. They don't know when, but in the next less than 10 years, it's going to be there. They already know. So you have climate change fueling this. The mosquito is feeling comfortable even in Patagonia in Argentina. We need to adapt to that. We need to respond. But it's so much that it's not that hard. And that includes, we have climate change. We have our societies. There's a lot to do. Economically, cultural change. And we have what we call limits to adaptation when it gets too much, like with heat. Heat can be too much to be able to work outside, outdoors. It's too much. It puts a lot of people at risk. So those are the limits to adaptation. And we need to restore nature. We need to, we have those losses, we need to restore biodiversity in many places in the world. We have all that. Like that affects how much risk you're taking. How much risk is really like, I wouldn't say like worth it, but how much can we take? So we have urgent action, we have timely action, and we have future climate change here that we need to limit climate change. And one thing that is clear, we cannot stop it. It's already here. There's no discussion at all if there is warming or not. The only conversation we're having is how much of it are we going to deal with in the future decades? And what is actually where we're going to say, okay, stop. It's going to stop, and it's going to take hundreds of years to actually go back. So we need to respond to that. That is probably a message. We need to stop it because there are limits to adaptation, and because it's already harming. And it's already putting, like, I'm talking to you, it's like islands. You know it better than anyone, that there are impacts that actually life or death. So we need to stop it because we cannot adapt to it. And at the same time, as we sector, we need to grow. So how we're going to do that, that's what we're working on. And there are triple wins. This comes from strategic roundtables that WHO had last year. And it's not present in any document, but it comes from slides from Marianita, if you heard her before. To climate resilient health, we need to address the impacts, as I was mentioning. We need to strengthen climate resilience and environmental sustainability. And this is something that we keep saying and saying, that is not only reducing emissions, but it's also sustainability, because we need to tackle waste, we need to tackle plastics, we need to tackle toxics at the same time, and not only like carbon, like fossil fuels. There's a lot that we need to do. We don't need to forget. when we are developing, adopting renewable energy, we need to solve waste. We still have many problems with it. We need to do it. And we need to promote, and we need a lot more research on the health co-benefits of climate change mitigation, including for other sectors. And this is one thing, if you are at the table as a health voice in your communities, in your states, nationally, bringing the health voice, that is useful, for example, to change the transport sector and all sectors that we need to change. And one of the documents that you can use if you start working on this is WHO's guidance for climate resilience and environmentally sustainable healthcare facilities. It has many checklists that are quite complete, not complicated, but long. They're super, super long, but you can adapt, adapt to your own needs. So this is another thing that I wanted to use. And one of the last things to share is that adaptation policies in Latin America remain weak. Please read the latest Lancet Countdown. I think it's a good one for us, short and very precise recommendations. Adaptation in policies in Latin America remain weak. We need to get better at this. There is a pressing need for robust vulnerability and adaptation assessments to address climate risks effectively. We need more of this. And we need locals. One of the things that the Lancet Countdown saw, it's like we have some national vulnerability and adaptation assessments. We have very little, just a small number of cities doing this. And we need a lot more local data on this. And that's something that probably you can contribute to. But they are scarce in the region. So that's something that we need to work on. So this was a short, we have a lot to do, but we cannot solve this alone. So how to partner was one of the things to say is there's a network that I used to work. I was part of this. Healthcare with Our Harm has a network, and it also has an initiative that is called the Healthcare Climate Challenge, that maybe some of you know, that is interesting if you want to do more. And it's the Global Climate and Health Alliance. It's a very good network of healthcare professionals from all over the world, but it has a chapter in Latin America that probably you want to join. And if your country joined, attached, that is the Alliance for Transformative Action on Climate and Health, maybe you can ask, what are you doing and how you can help? So this is all, and what you can do as individuals, as always, think of what you can do to change your daily practice, like look around you, what can you do? Be part of the discussion, participate in the webinars, talk to your peers, and of course, we are there for you if you want to learn more or do more. So thank you very much. Muchas gracias. And that is my email, just in case you want to reach. And I'm sorry if I took more of the time, but yeah, this is it. Thank you.
Amazing, Ms. Risso. Thank you so much for this amazing presentation. And I think it clarifies the crisis that we are facing, and also how the health was putting in a kind of a snowball, that with the advance on climate change, we have more people getting ill, and the health systems are going to increase your emission. And that's why we need to put the health in the core, and also leading this whole movement, not only to give the example, but also because it's needed to our health, and to bring together a whole chain of changes in pharmaceuticals and medical device that can be changed, the whole productions, to decrease their emission as well. And I love the last slides, that was something that I would like to propose to all our participants, is that you're thinking about, after this training, what are you going to do with all this information? What you can do with all this information? How we can do our job, our role, because here we have many health professionals. So you can do in your institution, among your colleagues, but you are also an individual, a citizen, and you can also do it in your community, among your family and friends. So thank you so much. And everybody's thinking about that, how we can make it better and how we can do a little bit, because everybody has a part on this to solve this crisis. I would like to call the next speaker is Miss Julieta Frederick, who is a nurse in St. Lucia with a master's degree in nursing leadership and management from the University of the West Indies, Trinidad. Currently, she is a principal nursing officer for primary health care at the Ministry of Health and Wellness, where she coordinates and oversees the provision and delivery of community health service. Over to you, Ms. Frederick.
Thank you very much, Dr. Daniele, and thank you very much to the team. Can you see my slides?
Yes, perfect. Thank you.
Okay, and can you hear me perfectly?
Yes.
Okay, great. So good night to everyone, and thank you again for this opportunity to present this case presentation this evening on Smart Health Facilities project in St. Lucia. So just to be able to just give a brief history before we get into the presentation, St. Lucia was among 7 Caribbean countries which benefited from Smart Health Facilities project. Phase 1 Smart Health Facilities project was actually implemented in St. Vincent and the Grenadines, and phase 2 of the project was implemented here in St. Lucia in 2018. The project was funded by the British government and executed by PAHO. So in this presentation, we're going to look at what was the starting point for the Smart Health Facilities in St. Lucia, the impact of the SMART concepts on patient care services, the response of staff and clients to the safe and green improvements that were made, how St. Lucia is reducing on some of its carbon footprints in the clinical areas, and what are some of the suggested improvements and advice moving forward. So this slide here, this bar graph is actually showing our starting point in terms of the 2 PAHO tools that were implemented, which is the Hospital Safety Index and the Green Checklist tools. These were used to conduct assessments of our health facilities in St. Lucia. And the graph would represent the Hospital Safety Index scores, which were applied to 34 primary healthcare facilities following the assessments. There were 3 facilities that were included. They were not primary healthcare facilities in that they were not delivering health services, but they were also included. The safety index score places a health facility into one of 3 categories. So health facilities in category A were deemed to have a safety index of 0.6 and above. What this would mean is that these facilities are considered safe and able to withstand hazards, and so health facilities will be able to continue operations or functioning following a disaster. As we can see here, no health facility met this benchmark. If you look in the light green areas, which is category A, you will see that none of the facilities fell or had that scoring. Category B facilities had a score of 20% to 59%, which is marked by the gray shaded area. This indicates facilities with a moderate level of safety or resilience and which may need minor repairs following a disaster. And the facilities in category C, that is the light pink shaded area, with a scoring of 20% and less, which would mean that these facilities are at least safe and would be subjected to extreme damage, needing major repairs and disrupting the continuity of health services following a disaster. So if you look at majority of the health facilities had scores which placed them in the lower category B and category C safety index. So this bar chart here shows the green checklist and the results with other health facilities. with 70% being the minimum green standard. The green standard scoring is also an important element for smart facilities. The greenness of the facility is considered a sustainable one at which conservation practices are implemented, for example, water conservation, safe waste disposal practices, and electricity savings. As seen in the chart, all 34 primary healthcare facilities fell below the standard, with just a few scoring between 40 to 50%. So following these results of the Hospital Safety Index and the Green Checklist, a few facilities were shortlisted and for retrofitting works to render these facilities smart. So in the first instance, 8 facilities were first identified. However, as you will see in the next slide, with additional funding being available, we were able to smart more facilities. So all the green bars here would represent the 15 primary health facilities that were retrofitted. As I indicated before, though we started with 8, because of additional funds, we were able to continue and to retrofit 15 facilities in all. I also want to indicate here that there were other health facilities that were not retrofitted, and this was due to other donors having those facilities having earmarked to be retrofitted by other donors, or because of the extensive work that needed to be done, they were not retrofitted. Also, the hospitals were not included. So as we look at this slide here, which showed the impact of the improvements in scoring of the health facilities, making them greener and more resilient. If I may just quickly go back, we had a similar slide which showed the categories of facilities A, B, and C. And if I may just go back 3 slides just to indicate, and we see how low the scores were. Following the smarting interventions, we see those improvements in scores, and we see facilities advancing or improving their scores to find themselves into category A and category B. So prior to the smarting of the facilities, most of them would have found themselves in category C or lower. So for an example, we have the Viewfort Health Wellness Center, which had a scoring of 0.3, advanced to a 0.66. Another example being Moshi Wellness Center, which had a scoring of 0.46 prior to the smarting interventions, that was improved to 0.68. So what were the smart interventions and how did that impact staff and clients? Some of them were favorable, some of them were not. So for the retrofitting works to have started, there needed to be relocation of health services. These health services were either provided in another location within the community, or in another location or another community, but within the same region. However, these caused disruptions in patient care. There was installation of side rails and ramps to facilitate clients with disabilities, that they could better access the facility for care. And also the washrooms were made, they were more disability friendly. Some of these measures were absent or minimal in some of those facilities before the retrofitting. With the installation of generators, there is continuity of power supply to the facility during power shortages, And so the cold chain for vaccines and other drugs are being maintained. In addition to that, with the continuous supply of power, our electronic health information system, our data records were safeguarded, and again, allowing for continuity of health services. There was improved lighting due to the LED technology and also improved ventilation, both of which contributed to the comfort of both staff and clients. Additionally, there's the use of low flow technology as it relates to the taps and the toilets for water conservation. The rainwater harvesting was another area at the health facilities that provided additional water storage, again, allowing for continuity of health services and maintaining infection prevention and control measures, for example, hand washing and sanitation. Lastly, each facility was able to develop their emergency preparedness plans, and training was conducted for staff in familiarizing themselves with their role and in the use of the various technologies introduced at the facilities. So how is St. Lucia reducing its carbon footprint in the clinical areas? Most of those are not necessarily as a result of the smarting interventions at the facilities. Some of it we were already implementing. So there is a national collection system that ensures the return of all expired drugs and vaccines to a central location, which is further transported to a major landfill for proper disposal. Before, there was the practice that health facilities would have had their own incinerators for disposing of medical waste. That has since changed over the years, and a private company is responsible for the collection of all medical waste for proper and controlled disposal. Also, we are using the reusable instruments and dressing sets as opposed to disposable ones. I mentioned earlier about our electronic health information system that is within our primary healthcare facilities, so we no longer have paper-based records. A brown paper bag day was introduced in St. Lucia a couple of years ago, and at specific health observance days, such as Hypertension Day, we encourage clients and patients to carry their medications to them to a designated location, and the pharmacist would review all the drugs, consult clients, and all the drugs or medicines in the possession of the clients, where the clients would probably not need them, the pharmacist would hold them back. So the clients would only be given the drugs or the medicines that are currently in use. So what are some of the suggested improvements moving forward? So we were very happy and impressed with the smart interventions following the retrofitting works that were done at the primary healthcare facilities. There were some challenges, however, as it relates to the ASIC technology. And there would have been a preference for an individual unit as opposed to central units. In addition to that, we noted that there needed to be more patient education when it comes to the use of some of those smart technologies. An example being pictures to be able to provide instructions on the use of certain equipment and some of those technologies. The generators were not adequately protected and positioned, and And so this left room for infestation by ants and by termites, which would of course interfere with the functionality of those generators. And living in the tropics, this was something that needed to be considered. Also, there were concerns of inadequate or repositioned exit points at the health facility to facilitate emergency evacuations. So this photo here just shows how satisfied one of our public health nursing supervisors in one of the regions when we were interviewing her when they first were reassigned back into the facility. And so those smarting concepts having been implemented have really empowered our staff at the facilities, having them be more familiar with those concepts, and they are better equipped in providing and delivering patient care at the various clinics. So in closing, I just want to acknowledge Dr. Judith Harvey, who was the lead PAHO consultant on the smarting projects and also assisted me in preparing those slides for presentation this afternoon. And once again, thank you very much for the opportunity. Thank you.
Thank you so much, Ms. Frederick, for this amazing presentation. It's good to see that the region is moving forward and many hospitals are already providing and also acquiring many adaptation and mitigation initiatives and all the necessary technology and change in infrastructure and education for the patient that's needed, all the context that's necessary to advance on the aspect. So I have many questions here. If people have questions, please put in the Q&A. We can address at the end. Most of the question was related to the role of the health worker. So thinking about that, we probably will have a question for you about this, their part, how they can do that. So I'm going to call the next speaker, Dr. Judith Harvey, who holds a PhD in engineering from Cambridge University and is a chartered engineer with the Institution of Civil Engineers in UK. She's registered as a civil and environmental engineer in St. Lucia and served as a technical consultant on their smart healthcare facilities in the Caribbean project between 2015 and 2023, where she supervised the retrofit of 12 health centers in St. Lucia, enhancing their mitigation and adaptation to climate change. And after the retrofitting, she arranged maintenance training for smart facilities in all of the 7 project countries. And she continues to promote the smart concept at events like this one. So over to you, Dr. Harvey.
So hello everyone, and this presentation follows from the presentations of previous speakers on this course. The introduction by Dr. Hospidales, the explanation and description of the PAHO Smart Toolkit, particularly the HSI and the Green Checklist by Dr. Paulson Edward, and the information presented today by Ms. Risso and by Ms. Cassius, dealing with adaptation, mitigation, and how the Smart Hospital project was able to achieve that. This presentation will focus on emergency preparedness and how the SMART project contributed to that in the health facilities. The focus is therefore on learning objective C, in which the main goal is the emergency preparedness, and the hospital safety index was used to assess the facility's level of emergency preparedness. There is a theme running through the presentation whereby everyday emergency preparedness is the key to being prepared for a climate-related extreme weather event or a nationwide disaster. And the takeaway from this presentation is going to be that preparedness is really enhanced by having plans for emergency repairs, for redundant provision of utilities and generally provision of redundancy, and reminders to staff, particularly by means of signage. So hazards range from human activities through biological, for example, pests, and geological factors, such as earthquakes or volcanoes. And the human activities have contributed to climate change, which leads, of course, to the climate-related extreme weather events, which have been the focus of this course. And these everyday emergencies create informal simulations or small preparedness exercises to help train the staff to be ready. And we will go through some examples of this now. The first example was an explosion of a generator battery with an acid spill associated with it. And this occurred during a medical clinic. So for the mental health, you can imagine that many of the patients there at the facility were quite upset. And in terms of the response, there would have been need for emergency repairs for mopping up of the acid spill, and it was associated with a power surge and power outage. So the staff would need signage or reminders to know where are the switches to turn off and to render the facility safe against any circuitry problems. So another example is to do with water supply, and water tanks can empty dramatically. Failure of the pipe work, for example, can empty an elevated water tank and flood the car park, as happened at one health facility. And the staff would need, again, some reminder which are the emergency valves to switch off that flow, that gushing water. But tanks can also empty gradually so that it's almost not noticed that they are empty until they are found to be empty. And Mr. Vlukman, who is attending this course, designed a water level measuring device for water tanks with that in mind, that staff could monitor the water level in the tank and not suddenly find that the tank is empty. And we have examples also having prepared the facility in having sound roof and foundation and good drainage, even to have catered to other aspects of the hurricane hazard, whereby strong winds lowered the power lines and the communication lines at this facility. The power lines and communication lines are hidden in the vegetation here behind the generator house, but they came down into the car park, and the staff would have needed to contact the utility company for emergency repairs. Another example similar to that occurred when a large excavator became entangled in the power lines adjacent to a health facility and brought down the electricity pole, blocking the access road and shutting down power at the facility. The facility had a generator and was able to function, but consider these emergencies, which are not extreme weather events, but which simulate aspects of the problems encountered during extreme weather events. This slide illustrates redundancy. There are 4 or 5 water tanks at this health facility, and yet 2 weeks ago, there was no water, the tanks were empty. This is a prolonged dry spell with water shortages being experienced, and that is the outcome. So redundancy cannot be stressed enough. And the generators at health facilities can be overprotected or not protected enough. In the Dominica example with the green and white housing, the generator was actually overheating due to the enclosure around it. But in the other picture, the generator was affected by the insect pests. You can see it is shaded only by a tree. And in fact, at one generator, a lizard short-circuited the controller. The lizard paid with its life, and the government had to pay for a new controller. So there is a balance to be achieved. And maintaining access to healthcare, even during an emergency, extends beyond the entry ramp and into the facility, for example, with these grab bars within the washrooms. And the Bahamas experience illustrated the need to plan for flexible service provision so that different parts of the hospital were repurposed to provide services which were needed and in areas where they would not have originally been envisaged. Also, emergencies on a large scale create a need for a greater workforce. And these are some of the tasks which are additional, needed at times of great emergency. So a register of retired or volunteer staff is the key to having this preparedness. And the disaster cycle here illustrates that we are looking at preparedness and the response to the disaster, but not dealing with recovery or reconstruction in this presentation. And the previous examples would have shown the different teams involved in responding to the emergency, from the medical staff through the ancillary staff, needs for cleanup, through the need for restoration of services with technical and maintenance staff. And the responders, the first responders, some of them are listed here. And it is noteworthy that the driver of the ambulance pictured here has received training in generator emergencies and generator basic maintenance, so that he's able to do more than one might expect. And therefore, the presentation has illustrated throughout the importance of having signage to remind the staff during emergencies and in times of stress, not only of exit routes, but of locations of emergency switches and key phone numbers for contact of those who can restore, creating the continuity that is required at a health center to restore power or to deal with the emergency. And therefore, the takeaway from this presentation is the importance of emergency repairs, providing redundancy, and giving reminders, strategic reminders to responders. Thank you.
Thank you so much, Dr. Harvey. We have many questions here in a few time. So most of the question was already covered by Dr. Harvey about practical examples that can be done. But I would like to make a question for all of you. I would pick two questions here, and I think all of you can respond that. So one is, how do health workers control or influence climate change financing? Is this really in our control? The second one that I think it's related to that is, what partnership can health facilities form with local governments, community organizations, and other stakeholders to improve community-wide resilience and response to climate change impacts? So we can start with Ms. Risso, and then we can follow the presentation order.
Interesting question. With the finance, I think it's, yeah, they have all asked that about that, right? About probably the scales, probably what is probably many times hard to see what's where you can act. Actually, it's like you're super far from climate negotiations, international negotiations, and the Green Climate Fund and all that. You're nothing to do with that. But PAHO and others are there. So probably to understand where you are in the system, this is what I said before, like we have partnerships, like there's the Climate and Health Alliance. There are places like this that build community, that build networks, your own facility, your own state, your own nation. So how that can, like, probably how that can have that butterfly effect, so that funding comes in a way. And how can you, depending on where you are, if you're a researcher, if you are implementing at the hospital, if you have access to politicians that write bills and make laws, like depending on where you are, I think. And if you understand that no one can do it alone, not even a country, it's that we understand that we need to build this ecosystem where we can all solve it together in a way. And the funding, and it depends on the funding for what. Do you want the funding just to build a climate resilient healthcare system for your whole country, or do you want funding just to have solar panels? It's like that, it's a lot more doable. I don't know if I'm adding confusion here to the table. I don't know if my colleagues have something more to say, but thanks to everyone.
Thank you, Dr. Frederick. Ms. Frederick.
I think what I can say for this question is I think now more than ever, climate change and health is a conversation with policymakers right now. So once there is that conversation, I think the onus is on healthcare workers to ensure that we continue the conversation. And once we can continue the conversation, I think it creates avenues where funding will become one of the aspects. I think we've done well in terms of the smart health facilities. We've had quite a few working sessions, looking at how health impacts various health conditions, the impact on various health conditions. So I believe that once we continue the conversations and policymakers are part of those conversations, I think it can create an avenue where they can now look at funding, for the various areas and to help mitigate and ensure that we do the necessary things to be able to, to reduce the impact on the environment. Yeah.
Thank you. Dr. Harvey.
I would say that there is a lot of climate change related funding available, and it is partly to do with preparing proposals. But you asked a two-part question, and therefore, could you repeat the second part, since I think my colleagues have addressed the first part quite well?
I think people want to know how they can interact as a health workers with the community, with the government. People want to know how they can be engaged with all this commitment to also build climate resilience in the health sector.
Thanks very much. So I would say that there are going to be future presentations in this course, more dealing with communication, and it is to do with formation of groups, because the voice of a group is greater than the voice of an individual. This is what I would recommend. Thank you.
Thank you so much, you all, and I'm going to finish this session because we are on time. I just want to remember our participants. So I can share my screen. So our next session is going to be on next Thursday, where we are going to discuss the changing climate and health equity, which is a very important topic. We will have Dr. Carlos Guzman, Associate Professor in Global Health from the University of Maryland, Ms. Stephanie Chowalan, who is the head of environmental inspection of the Bureau for Climate Health in Suriname, and the moderation from Dr. James Hospedali. And to finish, thank you all, and please complete our survey about this session. Thanks.